Okay. Welcome to today's meeting of the Health and Social Care Select Committee at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon London. The purpose of this committee is to monitor services provided by health partners in adult social care and review their performance. We also undertake in-depth reviews and witness sessions on specific topics and submit our findings to the decision-making cabinet. My name is Councillor Nick Denys and I'm the chairman of this committee. Before we start, I have some important housekeeping for everyone present. Please ensure that any mobile phones are on silent. We do not expect a fire drill, so if one does go off, please follow Nikki wherever she goes. Please keep your microphone muted when you're not speaking, and then unmute to speak. As chairman, I will call on those to speak, so ideally if people could talk through me, but that tends to work well. So okay, so we're going to move on to the first item. Do we have any apologies for absence?
Chairman, we've had apologies from Councillor Chapman, and Councillor Davis is here as his substitute.
Thank you, Darren, for coming to spend the night with us. Do we have any declarations of interest before this meeting? No, we're all good. Item 3, the minutes of the 21st of February. Does anybody have any comments on these, or are we happy to approve them? We're happy to approve? Fantastic. Okay. And number 4 is to say that, are all items in public tonight? Yeah, all items are in public. Excellent. So that means we can move on to our first main agenda item, which is witness session 2 for the CAMHS referral pathway. And we've got a really great set of witnesses tonight who are going to basically, I've given them all a challenge of telling us really interesting things within 5 minutes each, and then we'll open up to questions and discussion after that. But essentially, what we're really interested in is how is the CAMHS pathway working? How can it be improved? Are we giving good enough support to our young people who are suffering from mental health issues and the parents who need to deal with that? So those are the main sort of subjects that we're looking at. So if I've written down an order, and I've told everyone the order they're going to go. Lisa, you're going last. And it's not because you arrived last. That was the pre-plan anyway. So I'd like to start with those from the education sector. And actually, to be honest, I don't mind who goes first. Do you want me to pick randomly, or do you want somebody wants to put their hand up? I'm going to pick randomly. Alison, do you want to go first? She's the one person who's not here. Brilliant, that's perfect. She's the one person who's not here. If there's a choice between left and right, I always go the wrong way. Okay, so is somebody here in Alison's place or no? Okay, right, excellent. I'm going to go for Amanda because I can see you're here right in front of me.
Hi, I'm Amanda Erasmus from Uxbridge High School. I'm the Cinco and DSL there. So we have, I would say, during COVID, started referring as a school to CAMHS directly, and we found that works really, really well. And through the referral process as well, we have built up quite good contacts with the people and the staff and the therapist who's working there. We've referred up to date in the past 2 years 28 pupils to CAMHS. Not all of them has been accepted. 5 has been accepted, but when the letter comes back, we find it quite useful because they show us the different pathways. And I think for us in schools, it is quite difficult sometimes to know exactly what is out there for mental health support, because I had a look at our SEN register, and 5.9% of the whole school population is on the SEN register for social, emotional, mental health, and most of it is mental health concern, not behaviour. We have also found that when we do contact CAMHS, they do get back. We join in with meetings, either through Teams, online, or I have sat in with sessions, and that's really helpful because we have quite a close working relationship with CAMHS. And what we found as well is with parents, it's nice to have a meeting, almost a team around the child meeting with the parent, the psychotherapist or whatever therapist they are seeing, and the school, so that we can all work together, because the schools see the kids most of the time. We have last year, January, and I was really excited about this, we were approached to be part of a pilot for the mental health support team, which they started in Brent first, then moved to Harrow, and they're now in Hillingdon. We are one of 2 secondary schools in Hillingdon. So we have mental health support workers in school. We have 3 coming in twice a week, and we have referred 50 students to them, so they focus on, sorry, I've printed it out just to make sure. They focus on mild and moderate anxiety, low mood, worry and panic management. They do not help students who have previously self-harmed or have worked or is currently involved with CAMHS or has a mental health diagnosis beyond anxiety and low mood. But what we have found is I have weekly supervision meetings with the supervisor from Hillingdon with the mental health support team, and that's really good because we can discuss cases. We speak to parents about it, so parents is quite aware, and when parents come to us, we always say to them, well, if it's low anxiety, because what we found is if we target it when it's still on a low level, it's so much easier to manage, and that's where the mental health support team comes in and helps quite a lot. And it's having those discussions, and what happens in the supervision meetings as well is they will say to us, but maybe why don't we do this? Or there's this charity that does this if they don't meet the threshold. And we had 4 cases where they have referred through to call CAMHS. So that's our experience, and I think it's fairly positive. We had a meeting this week with a mum who just felt that the psychotherapist didn't really support them, and so I've sent the psychotherapist an email, and I'm just waiting for a reply. But it is that communication, and I think with CAMHS that works for us and our families in school. Okay.
Yeah.
Hi everyone, I'm Summer Wessels, I work at the Darry Masters School. I'm one of the deputy DSLs there, and I'm also the lead on mental health. We've been working with CAMHS for a number of years now, particularly since, like Uxbridge said, since the lockdown and the return. And again, it's been a very positive experience. In terms of referrals, our policy at school is that once a child is identified as having a possible mental health difficulty, we always ask parents to take them to their general practitioner. And if what we prefer is that the GP does the referral to CAMHS after they've actually seen the child and made an assessment on them. And then if the parents ask us, if the GP has refused to do a referral, we feel that we have the evidence at school, then we will do a referral. And we've done probably about 5 referrals in total in the last 2 years, all of which were replied to within 24 hours and all of which were accepted. So it wasn't, the incorrect judgment of the GP. It was just maybe that we knew more about the child. One of the things we found that in our policy, obviously, to ask them to take them to the GP, that generally we found that the referral from the GP generally gets refused. And when we've gone back to lots of GPs where we've said, we can't understand, this child is not coming to school, this child is self-harming, this child is, showing signs of low mood, we do ask the GP what was written in the referral, and we found that sometimes that the GP, because they are particularly busy and they're overwhelmed themselves, that the referral, when we've approached them and we've approached CAMHS, that the information the GP puts down is just nowhere near what CAMHS need to see in order to make a comprehensive judgment, and that's why often it does get rejected. So I think there is one of our biggest battles, and we don't plan to change our process of asking the GP. So therefore, we come up with, unfortunately, under a lot of referrals that aren't accepted. But if we really feel and we will back the parents, we will contact the GP and speak to them about that. So that's one of the areas that we find that there's a fall down with the referral process. And we don't expect to be doing lots of referrals as an educational establishment. We will do it, but actually it's very time consuming, and we prefer it to come from a medical professional. In terms of CAMHS and responses, I must say that they'll generally respond if you email. There'll always be an email to say it's been passed to the general manager on duty. They will always contact us the next day. In terms of the practitioners, I won't name any, but they've all been very, very good. They're very hard working. They will always attend meetings, very much like Uxbridge. We attend lots of meetings. I've been in 2 professional meetings with CAMHS this morning with social services, and what they try and do, we understand they're very stretched. In terms of therapies, there can be a big wait, and what's happened with our school is that we have employed our own sort of bridging services. So we have Place to Be. We buy in their services, and we've had a 2-year plan with them. We found that wasn't enough, so now we're employing a counsellor on a Monday as well. in order to take some of this weight of number of children that need to see someone. What happens is they're always on the CAMHS wait list, and we alert CAMHS that they're having intervention with us, and then once the CAMHS become available, then we do a transition period with the councillors over to CAMHS, or if actually they've had a similar kind of goal-based intervention, then generally sometimes they don't need to go back to CAMHS, and that can be very good. We do refer a lot to the single point of access service offered by CAMHS. One thing I would say that parents have told us about that is that sometimes they don't answer the phone, and it's very frustrating for them, particularly as they advertise they're open 10 till 10. Some of the children, particularly in the sixth form, will report to us that, Miss, I rang the number, and I rang and I rang and I rang, no one answered. Or when they did answer, they said they were answering for the adult services, and that there was no one at their desk in the children's services, which is obviously 18 and under. So although single point of access have been very good with the school, they've come in, they've done presentations, they are open to contact with parents. I'm not sure whether or not it's as available as they have made out to parents and to practitioners, because obviously we can call, parents can call, and our pupils can call. So we found that we're giving out this number, but we're not really getting the right responses back from parents in a positive way. So that's something maybe could be taken on board. In terms of the mental health support teams, we've been quite disappointed with that service, going to be absolutely honest with you. We have emailed a number of times, we have gone on the mental health lead training with Place to Be. They've advertised this new service. You can't get hold of anyone. They don't respond to emails. They're out of office a lot. And actually, when I did finally speak to someone, they actually said you've got too much already in your school. So you've got Place to Be and you've got your own counsellor. But that is all out of an educational budget. Where we're paying for that, so that other services within the school are being streamlined. So we felt that the mental health support team could be much more explanatory. They could visit the school, they could explain that, we only got the second counsellor because we couldn't get any more help, and we won't leave the children without support. So that was something definitely that, we've been a little bit disappointed about. In terms of CAMHS overall, I would say that, that they do a very good job, and we are very pleased that we work with them, and we're very pleased that they're available to the school. Thank you.
Thank you for that. Alison, we're starting off with the schools, as you probably guessed. So your timing is perfect. So essentially, what we want to find out is your experience in terms of the CAMHS and mental health service support and pathway, and any experiences that in terms of supporting our young people and also parents and all this sort of stuff. And I've asked people, because if they could stick to 5 minutes for now, because then after everyone's spoken, we'll go to a general discussion. So can you talk about your experiences, please?
Yeah, of course. My name's Alison Foster. Hello, everybody. I'm sorry I'm late. I'm from Viner School. I'm the deputy head and one of the deputy DSLs there. I think a lot of things that Summer has spoken about would mirror our experience. I think for us, some of it's about thresholds. Sometimes we make referrals that we think, well, we'll make it. Sometimes MASH have directed us to make a referral and it doesn't get accepted, and another one that we think we're making this referral and it's never going to be accepted does. So it's very difficult when you don't get any feedback either about referrals. That can be quite tricky at times. I think at school we've got our own canon. I think we've got an occupational therapist that works from school, a counsellor. We work Transform UK, and our school nurse is often very helpful in terms of bridging that gap and chasing things up with CAMHS as well. I think what's frustrating, I think, for us is if a referral is made and it's rejected, we don't then have a clinical signpost somewhere else, I think, as schools. I think that's my concern at times. And then we have made referrals in the past that then it might hit a crisis point and that child might go through A&E, for example, to be admitted into hospital or receive urgent CAMHS treatment. But actually, via that route, there's generally a story behind that. We haven't just escalated to that point from there. And then when we trace back the story of that child, and we can see what we've been doing for that child and the picture we've been building up, I think you're right. I think the referrals from the GP don't often go through. I think that frustrates parents. And then they come back to school. We do know more about the children, but then that frustrates parents again when then you make the referral and it gets rejected as well. So I think sometimes we're in that cycle, but I think there's lots of positive work going on. There's lots of advice and free help that you can get for people. I think that's particularly true since the pandemic. We try to build a canon in school, but it's really those threshold cases that those students need support, and we're never quite sure. You can't look at it and go, that will be accepted. And I think that's our frustration. That's parents' frustration as well.
Thank you. Okay, and thank you to the three schools for starting off this session. It's always hardest to go first, isn't it? Can I have Teresa next from the Centre for ADHD and Autism Support? If you could speak in a similar vein to the others, that would be really appreciated. Thank you.
Yes, hello. So my name's Teresa Glynn, and I'm Director of Services at the Centre for ADHD and Autism Support. We actually probably come at it from a bit of a different angle because we hear from the parents their experiences, and I asked the team to sort of come up with some of the thoughts and comments that parents have sort of made while they're sort of attending our regular drop-in sessions. So we see parents on a regular basis from a large part of Hillingdon, and they're able to sort of share how it's been. And the things that they sort of fed back was that, as we've heard already, that they'll go to their GP and they'll ask for a referral, and the referral will be rejected. Now, remembering our client group is ADHD and autism, so we're looking specifically at those conditions, but quite often, as we know, there's other underlying mental health issues that go alongside those diagnoses as well. So when they're rejected, it's just a really difficult place to leave the family, and often not having any answers to why. I think that's obviously been a big issue for them. If they've already connected with us, we can obviously continue to support them to a degree. They also mentioned that signposting would be really, really helpful, so it may not just be us, it may be for self-harm or for any other depression and anxiety and so on. Another issue that they talked about was that, particularly with ADHD, the parents are encouraged to do a course first before they will officially give the diagnosis and then the medication, if medication is seen as needed in that situation. Now, that's absolutely right. That's following the NICE guidelines, and Hillingdon are completely doing the right pathway on that. However, it's sometimes the parents can't get on a course, or they are really concerned about their child because their child is at the stage of transitioning to high school, or maybe from the other side transitioning quite soon into adulthood and maybe at GCSE level and just had a diagnosis. And parents really feel that medication could be really helpful to help them to achieve what they need to. So that has been an anxiety for them. So I don't know if that's something that can be explored, because although I do think it's absolutely right to follow the guidelines, perhaps we need to be looking at the scenario of the young person individually and seeing if actually we can fast track if needed. There's often a wait time. One parent talked about it being up to 2 years for the wait to actually be seen, and that the age of referral is moving upwards. So whereas they'd be referring a child from age 5 suspected autistic, they may be waiting until they're about 7. And the families are finding this a little bit confusing because they're reading one thing and finding that as something else. They often then will receive an appointment and believe it's for the assessment, but it's actually not. It's a triage, and then they have to go back onto the wait list and wait again to be seen. And this again can take up to 2 years, which is a really long time for families and for young people to be waiting. They also find that they're being passed between CDC and CAMHS quite a lot, and I don't know if there could be some clarity around that. I don't understand how that process works, so maybe that's something that if we have the information, perhaps we can pass that on to parents. I think the other thing that one of our team brought up was English as a second language, and the confusion around parents who are struggling to understand, and they'll bring paperwork to us not really having clarity, and they will come thinking we can give the diagnosis. So it's sort of really helping them to understand that You know, different agencies have different roles, and maybe translation and help with support on that could be really, really helpful. Yeah, I think that's probably all. What I must add, because that all sounds really negative and it's not meant to, is that once they are seen by CAMHS, they're really happy with the service. So I think it's just once they get there. And I think parents are very tolerant and understanding that there is a wait. They are aware of the pressures on the NHS and health. So they're not upset about that, but I think they just like information, or where can they go in the meantime. And if they happen to find us, that's great, and if they don't, then obviously that's another issue, because they're sort of just left. Thank you.
Thank you very much. No, that's okay. I mean, obviously we're focusing on issues because hopefully we're going to try and help sort of shine light and try and improve those. So yeah, no, of course, but it's also important to remember the positive stuff as well as the issues as well. So thank you for that. Evelyn from Hillingdon Mind, would you like to go next?
Okay. Hi everyone. So I'm head of Adult Mental Health Services, which encompasses our new Young Adults project at Hillingdon Mind. So really I'd probably like to reiterate a little of what Teresa has already said. Just looking at some of the feedback that we've received from our service users and parents and carers, really does sort of reiterate what you've already said, Teresa. There was quite a lot of concern about the long waiting lists for CAMHS, and I've heard the same thing, that the rumour seems to be that it can be up to 2 years with little support while the young person is waiting. And also some concern around the transition phase when that young person reaches 18 years old, and then there's that transition to adult services, that there's a lack of support in the meanwhile while they're waiting for that provision to be put in place. I think, as I've already sort of said, that the lack of support while that young person is waiting for that initial assessment, there's that worry that that young person's mental health may deteriorate further. On the other side of things, I would agree, once a young person is receiving support, we've heard positive feedback. I think it's just around that waiting time. But from the sort of professional point of view, I think we're quite a fairly new service with regards to our young adult service, so we support 16 to 25-year-olds, and we have sort of really quite limited capacity with a sort of maximum caseload of about 25. So we are available in the meanwhile for young adults with mild to moderate mental health to pick up maybe some of that support, because one of the concerns was that while people are waiting for that support, they aren't aware of what else is available in the community. So maybe if there was some signposting available to sort of hold that young person in the meanwhile, perhaps a recommendation. Yep.
Thank you, that's very useful. Can you switch your microphone off? No, that's okay, that's all right. We all forget to do that, and so it's a common thing. Okay, thank you very much for that. So we've got Eamon here and Catherine from Hillingdon Hospital. However you guys want to do it, you're presenting whichever way you would like to.
Thanks very much, Councillor. Good evening, everyone. My name's Eamon Catter. I'm the Deputy COO at the Hillingdon Hospital's NHS Foundation Trust. And with me I have Claire Byrne and Katrina Walkup. And Claire is the Divisional Nurse for Acute Medicine and Governance in Unplanned Care, and Katrina is our matron for the Emergency Department. So they're both very well respected stalwart figures from our trust. And they're here because really they're frontline workers and will be able to give particular detail about what it's like on the front line for the CAMHS patients and the experience they have in their pathway through the hospital. I'll just give a very brief introduction about the pathway and the experience. Essentially, CAMHS patients come to the hospital in the same front door manner to which any other patient would arrive at the hospital. So that could be through an ambulance, through a walk-in, brought by the police, and they come to our A&E department and present in the same way as any other patient. Once it's identified that they are under the age of 18 and they have a mental health issue, then CAMHS is notified. And CAMHS is notified through a direct phone line which runs 24 hours a day, and we only have one central phone number for the hospital. So the patient arrives, is in A&E, is triaged, is seen, and the phone call is made, and then the CAMHS team sends out a team member for a CAMHS assessment, and that turnaround time, I believe the aim is to be an hour, and they will then run a CAMHS assessment. Now that assessment runs in parallel with a standard assessment that we will run in the hospital for the actual physical health of the patient. So obviously we are an acute hospital that provide care for sick patients, but that does not include mental health issues. So that's where CAMHS comes in. So essentially at a broad level, that's the patient flow and pathway, and then the patient exits through the CAMHS planned care program. But in terms of their time in the hospital, in terms of wait times, in terms of experience, and in terms of potential areas of improvement, I'd like to hand over to Katrina and Claire.
Do you want to take it from here? So our children arrive, and as we said, it's a parallel assessment. We'll contact CAMHS at single point. During the day, that's a local CAMHS team. Overnight, that is covers a number of boroughs, so there is more delays at night time because they do cover Ealing, Northwick Park, those other areas, so we do have delays. They will come in, do the assessment, and as we said, even if that child is in there and needs medical treatment as well as a mental health assessment, they will do that as well. They may not come and see that child immediately because of not being medically cleared, so to speak, in the fact that they may, if they've taken an overdose, they might be very sleepy, drowsy, so you can't do a full assessment, but they will take their name and they will contact in a few hours' time to see how the child is doing and whether it's appropriate to come and do that mental health assessment. If it is a child with just who's been medically cleared and feels that the mental health assessment takes place, CAMHS will come and see. It's a very good service. We know the teams very well. They're very responsive. They will do that service assessment, and they will decide that the child may need a cooling off period, which is to give them time to allow them some space from whatever may have triggered their crisis, and that they would come and review later. Now that's probably one of our areas that is tricky because we don't have any mental health assessment beds in our hospital. We're an acute medical hospital and we have no assessment beds. So actually what that means is for the under 16-year-olds, 15 years and 364 days, they will stay in the paediatric area. As soon as you reach 16, so the 16 to 18-year-old, that means you stay in our adult A&E department. As you're probably all very aware, adult A&E departments are very noisy, very busy. Our department has a lot of space constraints, so actually the environment for these children and young people is not ideal for an A&E department to try and get that rest to be able to allow themselves to heal sort of and have that time to themselves. So there is issues with that. There is also issues if actually they need a tier 3-4 placement bed. There is very few beds in the northwest sector, unfortunately.
Sorry, could you explain what a tier 3-4 bed is?
All right. So that's so a tier 3 bed may be child who needs to come in on a section or needs to come in as an informal patient, and also do they need a secure placement and what type of placement, and if they've got what additional needs they have. So CAMHS will make that decision. That's not down to us. They will say they need this bed, and they will contact the hub, the mental health CAMHS bed hub, to say we need this child with this type of bed. The problem we experience is that there is not enough mental health beds for the children that we have, so the children spend a protracted period of time in an ED department, or if we know that they're going to be coming in and we have the capacity, we will, if you're 16 and under, we will send you to the children's ward, which obviously impacts on the medical beds for our children, so there is a knock-on effect. And then obviously, if you're 16, it's done on an individual basis, so some 16-year-olds would be suitable to go to a children's ward. Some of our 16-year-old children with mental health issues are not suitable because of the risks that they would pose to the children on the ward. So it's a fine balancing act for us to decide which way we feel that they need to go, and they would end up on an adult ward. And again, there's issues with being on an adult ward and what you're being exposed to as a child. So they're the issues that we face.
So just to mention then, just for some level of assurance, so when we have 16 to 18-year-olds on adult wards, we generally have them in a side room and with a mental health nurse, because obviously we don't have mental health nurses. I think the biggest issue for us as an acute trust relates to when a child is admitted, and as Katrina said, they need a cooling off period. So that means that actually they don't need admission to a mental health unit. They either need support from social care, but actually where do they go in the interim? And actually, predominantly, they would be our biggest concern, because those children are then admitted, or young people are admitted to an acute trust with a mental health nurse, taking up an acute bed, because there isn't any other suitable environment for them. And I think that would be our biggest concern. Now, there's lots of reasons why children and young people will present to ED in crisis. You know, there may be issues at home that has triggered it. There may be issues from school, from friends, from social media. So they can't always be discharged back into the home environment. So that is our biggest concern. In addition to that, we have concerns around when we have particularly complex patients who are either transitioning out of children into adult services. So they also, because they're in that transition period, even if they need a formal admission, there is a question about whether or not they're suitable for an adult bed or whether they should be going to a children's bed. So I think there's a question around that. And then particularly, and it does apply to Hillingdon, when we have children who arrive to Hillingdon Hospital but actually out of area. That's an issue. I would say that CNWL in terms of CAMHS are incredibly responsive, and we do work really well with them, but actually our concern would be around those children who don't have an acute need. They don't generally have a mental health need, but actually there is a mother need, whether it's social care, etc., and there isn't a suitable place for them to go. So I think that kind of, I don't know if there's anything else that we need to mention from an acute perspective, but that would be our main concern, I think.
And I think sometimes the families, again, like education has said, some of the children that do come in, they don't need admission, but actually the parents don't know where to go, so their last port of call really is to come into us to try and access the help that they need for their children, and that is, we get that feedback from a lot of parents who turn up in the department.
No, thank you for that, and obviously we'll come back to questions on this. So our last witness before we go into questions, Lisa from Hillingdon Health Watch.
Thank you, Councillor. Hi everyone, I'm Lisa Taylor, Managing Director of Health Watch Hillingdon, and for those who don't know what we do, we are essentially the patient voice for the borough. So we gather patient experience and try to work with providers to improve services where we can. I will be brief, but I just want to caveat the feedback that I'm about to give with the fact that we haven't sort of formally done any research around CAMHS sort of since before COVID. So most of the feedback that I have is generally from parents who have possibly already made a complaint about CAMHS, but who are quite desperate, actually, and also from young people that I've met recently whilst I've been out and about in the community. So I think I'm probably just going to echo, I think, what people have mostly said, but I think in terms of common themes, lack of communication from CAMHS, I think, is probably the biggest one that I would say we come across, and it is things to do with the triage process and what parents are expecting that doesn't meet their needs, waiting times, and as has already been mentioned, the support for young people and the parents for a time which can, like you say, be up to 2 years. Parents have reported to us, and just if there has been an appointment, it's the follow-up from that. I often hear that there's no communication about what happens next. Sometimes cases are closed, and there's no signposting for support. So I think that's probably the biggest issue that I hear. Responding to complaints as well, I've been copied into quite a few recently from parents who have made complaints but haven't had a response.
I've already mentioned waiting times, but yes, just going back to that, the referral process that people have already mentioned, and sort of no feedback about why someone hasn't met the threshold and why someone else has. And you know, and I think just going back to waiting times as well, the concerning thing is, you know, I spoke to a parent whose son of 17 was referred to CAMHS when he was 15, and he's still waiting for support. And you know, the reality is that he's now experiencing further health inequalities because of that time. You know, his ability to leave the house has been reduced, which is affecting his ability to socialise. And there's a perception from parents that I've spoken to that children are sort of being left until they're 18 until they qualify for adult services. And there's a fear from parents that actually by that point it's going to be too late for their child. The young people I've spoken to that have experienced the CAMHS service, quite a lot of the time, and this is through no prompting, but they'll tell me that they've been through CAMHS and they just didn't feel that they were listened to or that their needs were met. And some of them leave feeling quite disappointed and looking for other ways to help themselves, either through sort of advice on YouTube or Instagram and on social media. The good news, I think, is that I've been working with Jane Hainstock, who is our Joint Commissioner, to sort of revive the Thrive Network meetings and just bring local services together, so that I think there's a lack of knowledge about what exists in the borough in terms of support for young people. And if the professionals can come together and create that awareness, then hopefully we can work together to try and understand what some of these challenges are and come up with some solutions. And CAMHS have been very engaged in that network as well. So I am really hopeful that there are some positive things that are being explored at the moment, and that we can work together to help support children and parents for the future and get them the right support when they need it. Thank you.
Thank you, Lisa. And I'd echo that. I mean, we had CAMHS and some others at our last meeting, and it's a very we're getting a very good in-depth look at what's going on, which is really great. And so I'd like to thank everyone for being here again, actually, because the evidence we've heard just now from everyone has been really interesting and actually given a lot of context to stuff we've heard before. And for me personally, it's strengthened other things that we've heard before as well, which is really good, which shows you that we're sort of probably going down the right path, but really interesting for us. So, and everyone was about 5 minutes each, so that was absolutely brilliant, very well disciplined. So we have to be as disciplined as you guys are. So I'm going to make one very, very short comment, and then I'm going to ask 2 questions, and I'll open up to everyone else. I promise I'll stick at 2. And my very short comment, which is something I've come across during this process, it is the threshold and the idea of rejecting. I just don't like that in any sort of way, because obviously I understand the purpose of thresholds, but the idea that you're rejected from it is just nonsense when there's a real issue which is having to be dealt with by parents, by the young people themselves, by schools. And I just think that idea of thresholds and rejecting just is so counterproductive. But that's just a comment that I'm going to put out there. I agree that thresholds need to happen as well, and triaging needs to happen. But my first question is actually going to be I could ask anybody questions, but I'm going to go to Hillingdon Hospital first. Just a moment of clarity. If a young person is given a bed but are they kept in that bed until they're physically fit, and even if maybe their mental issues or social issues haven't been resolved, they still get released, because essentially as a hospital you're more interested in the physical? Or are they kept actually in their bed if the physical issue is not so bad, but they have a mental or social care issue and they have got nowhere to go? What happens at that point?
So we generally, do you want to go? So we generally will have a professionals meeting and a plan when children or young people have been admitted to hospital, and there's a plan for where they need to go. Because whilst we may be an acute trust, we still have a duty of care. So I think we can't, we would not be discharging unless we have a plan and an agreed plan, and that generally is what happens in most cases. And whether that's with CAMHS or social care or whomever, then that is generally what happens.
Yeah. how do you think this can be resolved, this issue? Is it as simple as more beds, or?
It's not. No, it's not as simple as more beds. Yes, we do need some more inpatient mental health beds for our adolescents, but it's not. It's that where cooling off period beds, where do they go, where's that place, environment, and it's I'd love to have a magic ball and know the answer, but more beds I don't think is the issue.
I think the beds would address the issue for children and young people that need a bed in a mental health unit. It wouldn't address the issue for, actually, it's probably not in every child's best interest to be admitted to a mental health unit. There's a lot, there are consequences to that, and actually it may be not the best thing for the parent or for the child. But actually there is a question for us always about where then, if they need a cooling off period, if there's issues with parental responsibility, actually where do these children go and who cares for them? And actually if we knew the answer to that, we'd be trying to address it, but it's an ongoing issue for us as well.
One of the things that struck me about your evidence is when you said that people come to A&E, parents, because they don't really know where else to go, and I think that's sort of a broader issue that was discussed tonight. We've heard elsewhere. So thank you for now. So that's all for you guys for now. And my second theme is for Lisa and maybe Evelyn as well. It's about this idea of waiting until adult mental health services are available. Do you know why that is, or is it because our adult mental health service is better than what's on offer to children?
Well, I will say that's a perception of parents. What the reality is, I can't answer that, but it's definitely something that's come up a few times when I've been speaking to people, and I think a lot of it is to do with just confusion around the thresholds, and then the fact that there's no signposting if a child doesn't meet the threshold to other support services. So I don't know whether parents do think that adults is better, or whether their son or daughter might meet that threshold. I don't know where that perception comes from. Something to be explored, I think.
Evelyn, I don't know if you have a view on this, because obviously I know in mind you deal with adults as well. Does the adult system work better? A very big, broad question, I understand.
It is a very, very big question, and I would agree with. I think it's the perception. I think it's the perception. I think the feedback we receive is there's a lot of confusion about what is out there. I mean, obviously we're as I said, quite a new service, so it's perhaps understandable that people weren't aware of us providing services for those younger adults. But there's definitely that level of confusion, and I think signposting is a really important element. In the meanwhile, people could be signposted better.
Sorry, I think with children's mental health services, I think there's definitely a perception that it's just CAMHS, and that the GP makes a referral to CAMHS. Whereas I think with adults, there's Mind, that are well known in the borough. There are other places where you can self-refer, IAPT, and I just think the awareness isn't there with children and young people's services. So it's very much CAMHS is the answer.
And of course, if that's the case, then lots of people get referred into one place, which potentially creates delays and other issues. Thank you. Okay, I'm going to open up to the rest of the committee now. I could ask you questions all night, but that would be unfair and terrible chairmanship of me. Philip, do you want to go first?
I will. Great to hear of all the fantastic work that's going on in schools and other places. A quick shout out for my old school, Darry Martyrs. Good to see you represented this evening as well. So that's good. I've got a couple of questions. I'll do one at a time or together? One at a time. Okay. I've been grappling with CAMHS in one way or another in different roles for many, many years. I'm sure Councillor Palmer will identify with this as well. This idea of where we are with preventative services. Are they out there, or are they just not properly understood, or is it a bit of both? Certainly in my time, we've looked at mapping of what's out there, and we've talked about things like COOS and all manner of preventative support measures that might just prevent that onward journey into tears whatever, 3 or 4 in hospital. I just wonder, in a historical context, because Lisa, I'm looking at you, Lisa, because your predecessor in your role, one of your predecessors, Jeff Maslin, brought this up very significantly at the Health and Wellbeing Board at the time. And I'm just wondering where we've got to. Are we broadly where we were a few years ago? If the preventative services that are out there better now and more joined up, is it still an opportunity? Where are we now?
So I would like to direct that question to the schools and to Therese first, because I think essentially you covered a bit on that in your evidence, and obviously, Therese, you get people at all different at times coming in. So if those from the schools, I know it sounds a bit rude calling it the schools, but if anybody wants to come in on that, and you're welcome. If not, you don't have to, by the way.
I think for us it will be when we get a letter back from CAMHS which states they haven't met the threshold, but please look at, and they always start with SEND advisory service, the educational psychologist, and then we will refer to those things. But again, that opens up another can of worms, because referring to the SEND advisory service isn't as straightforward as they're making it out to be, which is and it's just getting the referrals out there, and who do we refer to? And I mean, we have a couple that we use, but I agree with Councillor. It's really, where do we go? We don't know what is out there and what is available, and I think for us that is the biggest problem, because we use the things that we know. Luckily, we have the mental health support team in school, which I think makes such a big difference for us, and it just gives us a more positive outlook. I don't know.
I mean, Summer and Alison, you in your school as well, you've put in your own preventative measures, haven't you, in order to try and deal with what's going on?
And I must say that, we came back from COVID, and the school was extremely overwhelmed by the mental health of all the children. And there's other measures that we've put in place and people we've employed to create our own sort of what we call our pastoral support and wellbeing team, and that is a number of mental health first aiders who have taken £300 each every 3 years of training. And what they can do is they can be on high alert at any point in the day, and always one is on rotation, so that when a child becomes overwhelmed, and particularly those suffering with mental health difficulties, they can be removed to a safe space. Because I think what's forgotten is that these children, with or without diagnosis, with or without CAMHS support, they are generally in school all day, and they are not sitting lessons having a wonderful day. They still have exactly the same problems that they have when they go home, and they do really, they interfere with their daily functioning. They do interfere sometimes with the teaching of the class, because obviously they are crying or they are upset, and it can be quite difficult. And I'd say when Councillor mentioned about preventative services, I sort of thought, we'll find out some new ones, because actually, I would say we only really know about COOF, and if you really ask young people, do they use COOF, they say no, they don't. And the reason they don't is because actually they find it quite scary. They do have to sign up. They feel, even though that their details will not be shared or kept, that actually they still have to give details, and children don't like to do that in case they're going in a confidential way, sometimes because they don't want their parents to know. And also, I must say that in terms of COOF, we have not had contact with COOF for 2 years. Only recently, in the last, I would say, 8 days, have I been in touch with the new area development manager of COOF, who has been very, very good, is coming into school to provide an assemblies to all year groups on the first Monday back, and coming to a coffee morning for mental health with the parents. But everything, someone left and everything went very quiet. Even we couldn't get hold of posters. So in terms of preventative services, I think they're very limited, and if they are out there, we are certainly not advertising them. We are making up our own posters saying, go to these apps, use this, use that, but actually it just doesn't seem to come to fruition, and parents and children don't particularly want to use apps. They want to see someone in person, and they want help, and I think that's the difficulty.
Alison, do you have anything to add to that?
I have a bit of a theory actually about children's services and CAMHS being that one point, and I think all the services that we've mentioned, as far as I'm aware, apart from an occupational therapist, they are not clinicians. And I think, for parents, that's a scary place to be, isn't it? My child's got a mental health difficulty, but actually, is this some sort of environmental factor, or is there something that's really clinical going on with my child? And I mean, we're not qualified, educational psychologists aren't qualified to say that. And that's why I think that a lot of children get directed towards CAMHS to see if there's something more clinical going on. I think schools have got some work to do, I think, in terms of, you know, there are some brilliant programmes out there like zones of regulation at that very low base level of stuff where you can get children and try and get them on track and be able to manage, self-regulate better. And I think that can be a role of schools. But, you know, I was at the ASCL conference the weekend. Jeff Barton was describing schools as the fourth emergency service, and it certainly feels like that since we've come back from the pandemic. And it is a changing landscape. I think we're learning. I've certainly learned things since we've been back in school that, and self-signposting, I think, as well, really digging deep to find where those services are. Because I think something that's come up, commonality here, is about signposting. You know, there isn't a bank of resources. The schools have, I mean, we can't get the place to be, and we've been trying for a long time to get them in. They're such a sought-after resource. So you're going out and you're getting councillors in, you're getting somebody else in, so it's like a bit of a piecemeal, bespoke thing. But I think that might be why people direct towards CAMHS, because they want to know, you know, has my child got ADHD? Has my child got an underlying condition, rather than, you know, is struggling in this moment in time? And I think the two things are different. Young people, you know, young children often talk about, I'm sure you have this as well, I'm really anxious. You're going into an exam hall, you're going to be anxious. Everybody feels that. So it's a common state of emotion. So it's also about the language that we're using with young people to describe, I think, you know, well-being. I'm not technically teaching people to suck eggs, but, you know, there is that expectation, I think, that a lot of parents use the words mental health, but also what they're really talking about is actually we have to teach our children some self-regulation as well. And I think schools have got a part to play in that, but again, it's resources, and it's where to find that help.
Thank you, that's really useful. Therese, do you have any views on this subject? So, Alice, can you just switch off your mic? Sorry.
Yeah, sure. So I suppose we see ourselves as a preventative service, and we're very often quite amazed at how few people know we're actually in existence, which is a shame, because we can hold families while they're on the diagnostic pathway. And for us, you know, what we see is a lot of families come to us, and young people that we work with come to us, and they're waiting, and their mental health is deteriorating while they're waiting, because you know, I'm suspected autistic, but what does that mean, and how can I socialise, and how can I feel less isolated? And so it just impacts, and we feel very thankful that the relationships we have got with schools and with with families and with professional services makes a big difference. We have to be very clear we're a mental well-being, not a mental health service, because the expectations again on us. We have had CAMHS, not from Hillingdon, from another borough, refer in cases that were just beyond our remit, and we were left with suicidal ideation, which we do get anyway, but really difficult, challenging young people that should never have been sent back to us. So there is a lot of concern. I would love to see everybody knowing about what we do, because we are we're an organisation that can really help, because once they are seen by CAMHS, there is then that discharge, because once the diagnosis is made, that's it. And that's right, their medical work is done, but we do such a lot to support through all the age groups and adulthood. So it's really important that that services like ours, and I mean HACS, who we cross-refer to them because they're the other side of the borough. So there's such a lot of support out there between the two of us that we can be doing, and we want everyone to know. And that there must be so many other organisations that we don't know about that could be helping us during this time.
Thank you. Philip, you had a second question.
A quick one, if I may.
Yeah, can you put your mic on? See, Philip's just proving that we do it still.
That's a £5 fine to the Mayor's charity. There you go. So I'm really following on from that. There's a question, really. I mean, you might want to direct this to Hillingdon Hospital colleagues. So there will always be children and young people who will need, tier 3 and 4 beds, but I guess there are quite a number. And I just want to make sure I've understood what you said properly. I think what you're saying is that there are those who you do deal with who with appropriate support at an earlier stage you wouldn't see in the first place. Is that a fair comment, or would you like to perhaps explain that one again quickly, please?
Yes, so there is some children that turn up to the emergency department and the parents feel at the end of their tether and that they don't know where to go for support, and so they turn up to the A&E department with their child. So then we then do the referrals to CAMHS as an emergency because they haven't been able to get them through any other way.
Last resort then, in a sense?
Yeah, it is a last resort.
Okay, thank you.
June, would you like to ask a couple of questions?
Thank you, Chairman. Great work you guys are doing, and it's good to hear the harrowing stories of our young people as it stands now. I think it's something that I resonated with because my granddaughter also has some mental health issues, and I know that the problem that her mom went through just to get some support, so I do understand. In regards to mind, you talk about the young people transitioning. How do you support those people that is transitioning from like 16 to 18 into their 20s? What sort of support is given to that?
So within our service, when a young person comes, let's say for example we get a young person under 18, all young people between 16 and 25 will receive support through our young adult support, and that is in the form of one-to-one work. We have a social worker that will complete that initial assessment, and it's a holistic assessment. Again, we're not medical professionals. We're there to support their mental well-being, bearing in mind that we're working with mild to moderate mental health as well. And a lot of the work that is involved initially will be around signposting and directing and direct referral to relevant services as well. So, for example, our young persons leaders put together a directory of support. It's an online version and a physical copy that the young person will be given. And we have that same resource as well for people over the age of 18. So we have one for 16 to 25, and then 18-year-olds. We also have some art psychotherapy and some life coaching, quite limited capacity, bearing in mind that we have a sort of caseload of around 25, but we do have that support in place, and some group activities as well. And then once that young person reaches the age of 18, if they wish to, they also then have our adult services available to them. So we have counselling, again, for mild to moderate cases, and we also have a number of activities that we can offer. We have group activities, employment support, support for therapeutic support as well. So we have a range of activities that we can support them with at Mind. And also we will be helping them to navigate into appropriate services out in the community relevant to their age. I hope that answers the question.
And just one more question, and this is the Hillingdon Hospital. How do you cope with the kids when you have no beds or anything, and what is the atmosphere like with those children and the parents? Because obviously anxiety and concerns and not knowing, that must be something horrid that the parents have to go through.
Yeah. It's very challenging for everyone concerned, the child, the parents and the staff at times, depending on the condition of the child, if they're very aggressive and that. So some of the staff also need support, so it is very challenging, but we do use our mental health nurses to come in and support us as well. So these children will have a one-to-one registered mental health nurse with them, so they can help us support as well. And then on the wards, you've also got, if they go down to the children's ward, you've got like play specialists and other people that can come in to help support. And the CAMHS are very good, so they will help give some ideas. We've also got our learning disability nurse that will come in and give us some techniques and training and that, but it is challenging for all involved.
Can I just make an additional point, and sort of following up on previous discussions? I suppose from my perspective of the trust as an acute trust, we're sort of in the middle in that there is nowhere else to present if a child is in mental health crisis. So they'll present to our A&E. And it makes sense to an extent because there also may be a parallel need for physical care. But I think we either need to, in the long term, look to go one way or the other, and that is to say, if there's a mental health crisis for a child, there is a mental health crisis centre or somewhere else they can go rather than an acute hospital. And that would obviously then facilitate appropriate care where they're not being put in adult emergency, being kept waiting for a CAMHS bed, because they go immediately and it's known where to go if your child is suffering from acute psychotic episode, for instance. Or alternatively, we go the other way and say that the hospitals will always be the front door for these episodes, but then we need to actually resource and furnish the hospital with what's needed, which would probably be a separate area, the right staff and the right care, so they can be treated in an acute setting, but also with the resources that they need in terms of trained psychiatrists, psychologists, and trained mental health people. But the hope is that Hillingdon gets a new hospital, and that could be, if that's the sort of a 5-year plan, we could tie that in and create the requisite space and resources as part of that plan. But it's sort of going, I feel we're somewhere in the middle, which is they come to us, we're not resourced for them, but it's logical that they're with us, but then they're moved on, and we're this sort of middle point that doesn't quite make sense.
Thank you. At our next meeting in April, Hillingdon Hospital, among others, are coming to our meeting, so we will talk about the new hospital there. We actually talked about it 2 meetings ago, so it's something that we know how important it is, but thank you for that. Lisa, do you want to come in?
Yeah, I just wanted to pick up on that point about parents presenting at the hospital, because I hear this a lot about what do we do to keep people from coming to the hospital, and I think you've made a really, really good point, is that that's what people do if they don't know where else to go. So either we have to put a resource into the hospital, because I think to change behaviour is a really difficult thing to do, and I think it's important to meet people where they're at. So yeah, thank you. I just wanted to pick up on that.
Yeah, no, that's a very good point. Rita.
Lovely. Thank you, Chair. First of all, thank you everybody for being so open and frank today. I can hear your frustrations while you're trying to do the best that you can. So I'm going to make a quick observation, and I've got just one question because I'm sure everybody else has got similar questions. Alison, you're right, you're not a clinician, and it must take its toll on you guys as well. So, hats off to you guys for doing the best that you can. I think what I've picked up today is a lack of communication. There's an issue with the referral process. There's no feedback. But the biggest thing I think that maybe we need to look at in a separate item, Chair, is where do they go in the interim period? Where do the parents go? Where do the children go? I think that's a bigger question that we won't be able to answer tonight, but something that we definitely need to explore. My question is to Teresa. I don't understand why the parents have to go on a course.
So under the NICE guidelines for ADHD, then if it's a diagnosis of possible mild to moderate, then they would suggest behaviour management and a parenting course for the parents, which can be really helpful if the parenting course has psychoeducation within it. If it doesn't, then it's not necessarily helpful. And I speak from personal experience because that's what happened with me and my son. So I know that once I went on a course that had psychoeducation connected to it, I then understood him and I understood why he was having the struggles he was having, and that was affecting his mental health and mine. So I think there was a big knock-on effect of how effective it can be. So if you follow the NICE guidelines, that's what they would recommend first. For moderate to severe, they would recommend parenting course, behaviour management and medication, because the medication can make a massive difference if it's effective and if it works. So I think the difficulty is my understanding at the moment from the parents that we've spoken to and the few people from CAMHS I have spoken to is that they are doing that process throughout, that they will follow the mild to moderate first and then they will look at medication, which can work fine for the majority, but there may be some who really do need to be on the medication or to try the medication, because that could make a huge difference of being able to stay in school. I'm sure the school will agree with me on it. It could make a massive difference to their educational abilities, so they could actually achieve what they are capable of achieving. And it will also help their social and emotional well-being as well. And it's not forever, but it would have a massive impact. So I just think that system needs to be probably looked at personally, because I think we could make a big difference if there was more of a case-by-case. And maybe they do, I don't know, but it's just the parents we've seen that are really, really struggling with having to go on a course that doesn't necessarily meet their needs. We do offer that psychoeducation to parents in course, but we only can run so many, so that's the difficulty. Yeah.
Thank you. And like you said, Teresa, maybe something that we can look at in the future.
Yeah, I think that's definitely something for us to look at, because following good and best practice, of course, is very important, but you need to be adaptable. And you know, if there are serious issues and you've been waiting, and then you get sent on a course, and the course doesn't really fit, and that course you had to wait for, and that means you haven't got other treatment. I mean, that's, you know, it's definitely something that we'll look further into. Thank you, Darren.
Thank you. Just to echo what everyone else has said, you guys are doing a brilliant job. I'd hate to be in your position. I've got two questions. I could ask you hundreds, but I will keep it to two.
Two is the maximum, Darren.
Yeah. The first one is to the Hillingdon Hospital. When a child or a young person presents with a CAMHS issue, are they monitored in the waiting room? If so, if not, or if so, what happens if one of them children or young people disappear? Do we follow up? Look, yeah.
Yes, so they're all brought in. Usually the under 16 paediatric ED is a smaller self-contained unit. Most of them are accompanied by a parent. If they're not, we fairly quickly contact an adult to find someone to come in, but we will put them on a one-to-one. The 16 to 17-year-olds go in to our adult ED, and again, we will contact a parent or have someone, because sometimes school brings them in for us and someone stays, but we will then try to source an RMN as quickly as we can. Obviously, we don't have that workforce, and it's some days we'll have 2, other days we'll have 6 people that require it, so it's movable. And then if someone was to leave, our policy for anyone that leaves before treatment is that we would contact the police to do a welfare check, we'd contact parents, we'd contact our colleagues at social care to say that we've had this child that they've absconded. So we'd put all of that into play as well, and follow up from there.
Brilliant, thank you. Second question, if I may. This one's to the schools. So at the moment we're talking about the CAMHS process, but what happens with the parents that are in denial? That there's nothing wrong with my child, she's just being, or he's just being a young person. Do you have anything in place to sort of mitigate that? That if a parent doesn't accept there's a potential mental health problem? Or is that something that we need to look at? Bit of a tough one. Yeah.
Most people are looking for support, I think. They recognise something. I suppose if I was in that situation, I'd probably, and it went on, you'd probably contact MASH, you'd probably contact social services and say it's an issue of neglect. I think that's where we go with that.
That's brilliant. And you guys not really having an answer as such means there's not many cases like that, which is excellent. Thank you.
Thanks, Darren. Tony.
Thank you, Chair. And I'd just like to echo what other councillors said about the marvellous work that's being done. I mean, it's certainly a lot different from my school days, and you know, I'm glad to see it. Just Councillor Davis has partially asked the question, but asked my question. But when CAMHS don't accept somebody, do they give you a full reason why they don't accept them, or is it just a non-acceptance? And you obviously, it's up to you to turn. They don't give you any recommendations for treatment or anything. You just get a refusal from CAMHS.
So we will receive a letter that just states they haven't met the threshold, and they will have 3 bullet points of where we could signpost. Couth is usually one of them. But the discussion we had here tonight is what happens in the interim, and the answer is schools pick it up. And we are not mental health professionals, and I think that, as a school, is the difficulty, that we can refer to all these services, but an educational psychologist won't be able to help us. The SEND advisory service is not going to help and support unless a student has an ASD diagnosis or ADHD diagnosis. So it is really, really difficult. I think for us, schools pick up the ball, and yet we need to just deal with it. Everything stops at the school. And I don't know if you guys feel like that as well, but it is all down to us, and we are not the specialists at the end of the day.
Just to follow on from that, I mean, there's the question we don't ask about exclusion. Does it come to exclusion of a lot of these pupils?
I think for us, as a school, we try to avoid that at all costs, because we work with a behaviour support team, and there's different things you put in place. And when we talk about mental health, I'll talk about ADHD in a moment, but for mental health, it won't lead to exclusion. It will have a look at a really personalised timetable, and we are quite lucky. At Uxbridge High, we have quite a big pastoral team. We have a flexible learning centre where people are there, and we can run groups and we can run zones of regulation. So we are quite well set up. But again, it comes at a cost to the school, because the school is funding it. Students with ADHD, we will work with all professionals. We will refer to SAS. We will work with the behaviour support team. We will put all relevant things in place, and it hardly ever leads to an exclusion, because we as a school need to be supporting the child. Okay.
Excellent. Well, I think that's going to be the end of this session for tonight. Again, thank you so much for coming and speaking to us. That was really, really interesting. Has given us fantastic context on stuff we've heard so far. Just for you guys, your notice in a way, my feeling is sort of in early summer, we'll start getting an idea about what we'll want to recommend and what direction we're going in. At that point, I'll probably like to contact you all individually, not coming back to a meeting on a night time, but more in office-friendly hours for you guys, just to sort of run past some of our thinking and ideas as they solidify, because you will all be fantastic. You'll give us fantastic feedback at that point. So we will be in touch again. But thank you so much for coming and sharing your stories with us tonight. And you can all leave now. Unless if those who are interested in staying are very welcome to stay, but you're very welcome to leave. Okay, headline act number 2 now. So our next item is the Cabinet Member for Health and Social Care update. And so we have Councillor Jane Palmer here, who's Cabinet Member for Health and Social Care. Also Sandra Taylor, who's the Executive Director of Adult Services and Health. I will call you Sandra and Jane from now on, if that's okay. And you may call us by our first names, or not, depending on how you feel about it. Either way is fine. The purpose of this item really is, essentially, I think once a year, it would be great for the cabinet member Jane to come along. I know Sandra, you come along to us more regularly in a way, and I know you, Jane, you always watch what we do because Jane always gives me reviews of the meeting afterwards, which is really great. But just to sort of hear about some of the highlights and what you've learnt over the last year, and in this case it'll be about 10 months obviously since we had our municipal year, and also anything that's sort of on your radar to think about for the future, and then we'll have an opportunity to ask you some questions around that. So essentially you've provided a very good paper to us which sort of highlights the breadth of the work that's being done and what's being done in there, so thank you so much for that. That's very useful. But you don't need to go for everything here, just sort of, you know, what you think you would like to talk to us about. So Jane.
Thank you very much for inviting me, Nick. It's a bit scary having chaired the thing for years and now being on the opposite side of it. It's slightly intimidating. All I want to do really is to just you've read the report. There is absolutely no point me going through it again. I'm happy to take questions on it, but I think I would like to give an update at some stage about the integrated care boards. But let's look at the report first, if you like, if that's all right with you, Chairman. I think that where we are with social care is for me, social care is about prevention work. So that is what we work towards. No matter how brilliant these services are, what we start to do in the children's service and then into the adult is about prevention work. And that is what we are about at the moment in this council, getting in early with our young people and carrying that work on into our adult services. So nobody wants to go into sheltered housing, nobody goes, whoopee-doo, I can't wait to get into a care home. That just doesn't happen in anyone's life. So the aim of what I work towards and I see with the officers is prevention work. So I think a shining example of how we did that was COVID. During COVID, our social workers were absolutely excellent, and I want to give on record today my thanks and gratitude on behalf of every person in this borough who experienced social care during lockdown, because they kept that whole service going. And I think that reflects how good we actually are. So without highlighting any particular service, that is my overall thing at the moment. The report showcased very many schemes that we use, but we wouldn't be anywhere without the excellent staff and managers, one of whom is on my right, that allow that to happen. So I'm happy to take questions. What we don't see on here is something I am quite proud of, and that's the suicide strategy. When I came into the council, there was nothing around this council on suicide, and due to some quite personal experiences, that was something I worked really, really hard to achieve. And we now have a proper suicide strategy which looks at suicide prevention in this borough, and we link in very much with our colleagues from mental health, British Transport, and you know, we've done things in Hayes Station because that was quite a high place where suicides are. I've got to find the words very, very carefully because we can't stop it. It sadly is a fact of life, but what we can do is a lot of joint partnership working to ensure that the best support is there should somebody take themselves to that place. So that is something that I have to have some pride in. I'm happy to take questions, Chair. Sorry,
yeah,
I
thank
can't
you.
call you.
Yeah, no, that's fine. I answer to anything, even oi. Thanks for that, Jane. And I think questions are the most interesting part. And obviously, we'll ask some questions, and we can come on to the integrated care boards after that. Unless a question goes down that route, then you can go into it. Who knows? You know, you should be proud, definitely, because I know, I'm privileged to attend a lot of meetings with you, because in the health world there are a lot of meetings, yeah. There are more meetings than you can ever possibly imagine, and sometimes we attend the same ones, but I know this is something that means something to you. It's not just, a job as such, and that's really great. But so the first question I want to ask is around finance, because ultimately more social care is taking up more and more councils' budgets, and we're exactly the same on that. I think it's 60% of our budget or something last year, a high amount. And the actual expenditure on social care itself, when it's needed, is expensive. The preventative stuff is brilliant and needed, but also then another expense. I mean, are we able to put money into the preventative stuff when we've also got to spend money, of course, on the now stuff?
Every time anybody ever talks about social care, they talk about the money, and this council is no exception to that. So my personal view, which probably isn't going to be well received, is social care has never been funded properly at all, ever. I think the headline for this council is the biggest drain on the budget, and I don't even like the word drain. I mean, it's something we statutorily have to provide. It's a large amount of money for a very small amount of people, which I think needs to be acknowledged. And I might need Sandra to talk about the facts and figures of it, but the essence of it is, for me, it is about the quality of the service, always. And we have proper procurement. We have proper monitoring of services. You will see such... oh, no, actually you won't. It's in part 2 of the Cabinet papers. But you will see that if contracts are not being fulfilled properly, we do something about that. And social care, we've done a lot in our social care contracts to bring them down from huge amount of care providers to a very small amount, which has enabled better service for the residents, it's cheaper, and more effective monitoring. So it's never going to be easy, because in this day and age everything is more expensive, and coming out of COVID, social care provision is more difficult to find and more expensive. I mean, we're all paying more for our household bills and our heating, and that goes exactly the same with companies that are providing us with social care. So it's not easy, but I will say we are a sound council with sound financial management, and we are not going down the routes of at least one council has been unable to deliver their social care in quite the way we do. So I'm proud of the way we do it. It's never going to be easy, but I think we do it pretty well. I mean, if you want more, a little bit more information, Sandra will be able to hopefully give you that.
Thank you very much for your kind words. And yes, I think social care is always going to be a talking point about budgets. The spend is always high, and Hillingdon, I was going to say, is no exception, but actually we have a strong record in social care of good and effective use of resources, and that is absolutely built on Councillor Palmer's comment about early intervention. So we have a very strong in-adult services, strong out-of-hospital discharge process, for example, about using reablement, and at least, it changes on a regular basis, but currently 70% of people are coming out of our reablement service with no ongoing care needs. So if somebody's been into hospital, comes out and has no ongoing home care requirements or care home placement and goes back to their day-to-day life, that's a significant benefit to the council. And we know that history tells us that if you go straight into home care or you go into services, a dependency is created. And so early intervention is absolutely key. It's been a very interesting evening listening to the children's services, and part of my remit is obviously about early intervention and actually developing resilience among young people and adults, both in mental health services and physical health services, and my remit around public health and ensuring people are having health checks and developing good general health is something that as a council we do very well. We want to build on, and you can see those gaps, and we need to fill those gaps with primarily our third sector
providers, our voluntary sector providers, who support the majority of the residents that live in Hillingdon. So those are the people that we need to build strength in ourselves and our residents, and in turn that will manage our demand and manage our social care budget. The other point I'd just like to make is around the current levels of inflation, and Councillor Palmer's point around it's no cheaper, or that doesn't impact on providers, is absolutely right. Equally, the workforce is really challenged at this moment in time in social care and in health, and so it's essential that we pay the fair cost of care rate. We make sure that we're paying the right rate for care to ensure we've got enough people to care for people when, preferably in their own homes, and that's the best way of managing social care budgets, despite the fact that they continue to be challenged.
Thank you for that. My second question before I open up to the rest of the committee actually sort of follows on from the staffing stuff, because I think there's almost a moral duty anyway to pay good, social workers a good amount of money, because ultimately they do such important work. But not just the money. I mean, what makes Hillingdon a good place to be a social worker and work in our social care team? Because I think, obviously all organisations and all bodies, even committees, the people are really what makes the difference. But I think in social care that's so true, because personal relationships, and you're dealing with individuals who you have to put in certain boxes in some ways, but they're individuals, and that relationship and getting them to know people is very important. So, are we a place where social workers want to work?
So I would answer that by yes, because I will go back to the COVID, the fact that the staffing was so high, people weren't off sick in social care during the pandemic. So that tells me something that is going right. My experience is that it is a good place to be a social worker. We have done apprenticeships. We have. I think Sandra will correct me if I'm wrong, but we do bring people in and they stay with us and we train them, and then and we certainly had people moving from one department into another. I experience it as very supportive. We have good working relationships. I certainly have good working relationships with the team, and I think that is important. And no, people don't go into social work because they don't like being around people. And I think that the culture of this council supports excellent social work. There's proper supervision, proper support. Literally, people's doors are open for people to come in and get that support. So I would say it is a good place to work, because certainly when I had fostering and adoption under my portfolio, I do not have that now, regrettably, but I saw their evidence of social workers coming back to work for us. So unless, I'm sure Sandra will correct me if I'm wrong, but it feels a good place to work. I don't think, can't say we're not struggling to get staff. It isn't as easy as it was, because it's perhaps, if something goes wrong with social work, the social worker always gets the blame. I'm not 100% sure what the recruitment's like at the moment, but my overriding thoughts are yes, it is a good place to work, and social workers like working for us.
Sandra, do you have any further details on that?
Councillor Palmer's absolutely right. We have things in place to ensure that social workers, but also we have a very significant range of social care staff working for us. Not everybody is a qualified social worker. So we've got some very experienced staff. Our retention is very good. My leadership team have a lot of years between them, and a lot of years of service, and have really good experience. And we ensure that we have good caseload management, so people are not overwhelmed. We have wellbeing services on offer to staff. We try to be as competitive as possible as a local authority, bearing in mind we're an outer London local authority. But equally, we push up against Bucks and Berkshire, and so we have to be competitive in our salaries. But we find that in the main, if you're a registered social worker looking for a role, actually it's about It's about how you're managed in the service, not about coming for the money. And obviously everybody goes to work for money, but it's actually about, are you going to be supervised? Is your caseload appropriate? How are you treated at work? Do you have the right equipment to do the job? And those are the things that we don't always get right, but we are working very hard on it at this moment in time because of the challenged workforce. That's not Hillingdon specific. It's actually a national problem and specifically a London problem. So we have a range of schemes at the moment, workforce development schemes, including recruitment of apprentices and newly qualified social workers, so that we can build those people into senior social workers and advanced practitioners, which are the very senior workers with the most experience that we want to retain. So there's lots of initiatives happening at the moment. So my answer is yes, it's a good place to work at the moment.
No, thank you. I'm a big fan of the apprenticeship scheme that you're guys doing. With another hat that I wear with the corporate parenting panel, I know about it because obviously we take people who are our children as well through that scheme, which is absolutely fantastic. So that's good. Anyway, that's enough from me. June.
Thank you, Chair. Just a good word of encouragement, Jean. It's encouraging to see that you're reviewing the London Borough of Hillingdon as a whole in the area, that there are regular meetings. It's good to see that. I've got 4 questions for you, and then I'll come back to one more. Is the council going to initiate this CQC inspection timetable to regulate service, which will ensure consistency while the CQC figure out their post-COVID approach? The second question is, how close...
June, should we do them one at a time? Because I think that's easier to answer, isn't it? Is it?
Yes,
sorry, microphone. Yeah, cool. So let's do one at a time. So that first one about the CQC then. Yeah, that was one. That was the first one. Okay, let's tie the two in.
The second one is, how close to the old CQC inspection timeline is the quality assurance team working? So that's the 2 together.
Okay, so I'm not party to those individual questions. I think all I know is that we are having an inspection. I'm not qualified to answer the question, so I will have to pass that to Sandra.
CQC's framework finally was published today, so and it's on their website, and we've been preparing for an adult social care inspection for some time. The framework itself is different to the identified detail that's in the report here. So we've got an inspection overarching over the whole of adult social care. CQC have published, because it's not completely through legislation yet, a draft inspection regime, and will undertake 5 inspections between April and September of this year nationally, one of which is likely to be London, and there will be a range of other local authorities around the country. There has already been some test and learn local authorities. I think there has been 5, and I'm attending meetings around what was learned and how CQC have learned from that, but also how local authorities can learn to present their evidence. And equally, the framework is very similar to the Ofsted experience of inspection, so we will be following the same sort of regime. It's a very engaging process to try and work with all partners, members, service users and their families to try and gain an understanding of actually what we're calling stories of difference, the difference that we make to people's lives, and how social care is improving, enhancing, helping people to live their lives independently. So that framework is something that we're all adapting to everywhere across the country, and we will probably see an inspection in Hillingdon at some point in 23-24. In terms of the rest of the inspections, the single assessment framework affects locally registered care provision. So that's home care, supported living providers and registered care homes. And
they have a new approach, which means that they do face-to-face inspections where it's warranted, or where there are they haven't seen people face-to-face for some time, and because of COVID they haven't. But monthly they do a review of things like the complaints, the safeguarding alerts, and any concerns raised, and they review all of the data that is sent to them by the care home managers. And so they monitor the services remotely primarily now. And in Hillingdon we have some directly provided services, and we've had a couple of inspections, but one face-to-face, which was positive.
Thank you. June.
Is there sufficient resources to be dynamic enough in the new way of working, and to adapt not just to the government changes, but factor in such changes with the NHS structure? And how does these changes locally impact on the joint working?
June, can you tell me what this new dynamic way of working is? Is there a new dynamic way of working?
I'd like Councillor Nelson to be more specific.
What type of, so obviously, what type of ways of working do you think the council should be sort of moving towards?
I think it's a join-up way of working with all the different links of the services that within NHS, social services, and the community in a whole.
I might cross that question if I spoke about the integrated care boards and the health and wellbeing board. So, for example, when I became cabinet member, the first thing I did was to restructure the health and wellbeing board, because it was top-heavy council and it was just a talking shop. So what I actually did was had a workshop, and then we now have a much more joined up way of working with our health colleagues. So it's co-chaired by me and a health NHS professional. And so what...
Jane, we know Keith, he came to our last meeting.
Keith Spencer, yeah. So, and before him, Caroline Morrison co-chaired with me. So that had, pre-COVID, that enabled us to do some really good working with our NHS colleagues, because we fostered a very, very good relationship. So in terms of the joined up working with our health colleagues, and indeed our voluntary sector, that is a prime example of how to do it. If you'll get round the table and you have some honest, frank conversations, like we saw earlier here with your very, very good, I have to say, review that you're doing, that is how changes get made. So that is the work that's going on. I can say to you that I take that work away from the Health and Wellbeing Board, and I am part of we are now part of 8 boroughs of North West London Health, and I need to Hillingdon, Harrow, Hounslow, Hammersmith and Fulham, Ealing, Westminster, Kensington, Chelsea and Brent. We are 8 North West London boroughs, and we meet together as cabinet members, leaders, whatever, and we discuss health inequalities, and then I go back. I am one of a representative on the integrated care partner, and I go to the health and to the integrated care board as a representative of one of those 8 London boroughs, and I talk about health there. So, for example, today I've been at the integrated care board with about 50 other people, and we have passed the business case for the orthopaedic hospital in central Middlesex, which I know this committee have fed back to. And Hillingdon were overwhelmingly concerned about the transport, and I want to assure this committee that what we are doing and what we have asked for is a transport working group, and I will be on that transport working group. And that is because for this borough it's an absolute nightmare to get to that hospital. So this board has my word that I will be working really, really hard to make sure that Hillingdon continue with working with our health partners to make sure that our residents, whether that's from my ward in Harefield where there is no station, or whether it's my colleagues' wards in front of me from the south of the borough, we can get to that place. So I'm not sure I've answered your question there, June, but what I'm trying to illustrate is that by Joined Up Health working with Hillingdon Council and NHS, of which I am, I've got to say, a large part, hopefully we can get decent services.
I can highly recommend the Health and Wellbeing Board. It happens 4 times a year. You can watch it online, or of course you can turn up in person in the papers, because actually it is really interesting. I turn up in person when I can, when my work allows it to, and it's a really good way of seeing how the different health partners work together. So I can highly recommend that as a meeting for people to look at if when they have time. June, do you have another question?
And it's thanks for reassuring us about the transport system, because it's one of the things that we discuss here as well in regards to how a resident's going to get from A to B. Just one more question. Is there sufficient capacity and expertise in succession planning around key specialist roles such as register management, and that's part of your report?
I just thank you, June, for what you said about the transport, and it's invaluable to me. That's why I watch this committee. So we do joined up working. So thank you for your comment. I'm going to duck out of the next question and ask Sandra to do it.
In terms of succession planning, the 3 registered managers in adult services currently have all worked in our services for many years and have worked their way through the system, and there's a structure in place that means you can become a carer, you can move to be a team leader, and you can have significant responsibility of a larger service or a smaller service, but we have some small 6-bedded units as well as our larger residential homes. And those individuals are the 3 managers of those registered care homes are incredibly supportive of their teams. They do really well. The services are rated almost always. I don't remember the last time they weren't rated as good services, and it's a good learning and caring environment for both managers and staff. There is registered manager training available from Skills for Care, who's the social care training provider, and people can become registered managers through a whole raft of routes, which is around, it isn't just around care, because obviously they have to operate there as a business really. So they have their own budgets, they manage their services and report to a service manager that sits within the civic centre. So they operate fairly independently, and they become very skilled individuals at providing that support. It's really important that I'm talking about those 3 services that we have in-house, but equally we have 44 registered care homes operating within the borough. So we have a provider forum and we have a registered managers forum, so that they're well supported and they can continue their development and training.
Thank you. Philip.
Thank you. Yes, I've got a question relating to the document that was circulated. Excellent document. So whoever of you was responsible, thank you very much for that. It was a good, useful background. One thing I didn't see in it, I don't know whether it was just the way I read the document, was the position in relation to out-of-town placements for people with quite acute support need. We know that historically that's quite an issue for us in the borough, in fact disproportionately so, and certainly in my time we've grappled with that, and though it's easier said than done, we were working towards, where we can, moving people back in borough, and where appropriate, into less institutionalised and more supported care type provisions. I just wonder, 3 years on since I was in that role, where we've gone with that. Is that still the direction of travel? And given the success that we've seen with Grassy Meadow, Parkview and other places, how's our thinking developing around future provision in that regard, perhaps, given the budgetary challenges we're hearing about, which I'm sure are far worse than they were in my time? So,
I will ask Sandra to answer that, but that is still, obviously still on our radar, Councillor Cawthorne. It's something that we're always looking at. How can we do things better? How can we make sure that if our residents need a bed, there is one? And that is work that I know Sandra and I had a conversation about last week, in fact, because the point you raise is valid. So I am going to hand over to her where she can explain exactly the conversation we had from her point of view. Would be great. Thank you, Sandra.
Certainly, during your time as Cabinet Member, Councillor Cawthorne, we developed extra care housing and supported living for people with learning disabilities. And at that point in time, that was absolutely essential to tip the balance for the number of people in regulated registered care to living in the community and having supported living. And I can assure you and the committee that that is absolutely, the balance is well and truly tipped, and we have many, many more people in supported living than we do in residential care nowadays. You will always have the need for complex placements. We have people that have varying needs that we're not able to meet locally, and we will always need to look for some specialist providers, and we'll continue to do that. Those providers have very niche abilities, and some of the very complex people that we're talking about, probably some maybe of the people we were talking about earlier today that are presenting. So those are the ones that tend to be needing out of borough placements. Should we develop local services for those people? We have some, but we don't always have the very highest level of need. So that's something that I think that we need to review and continue to monitor and ensure. Where we can, we look for, some people we have in their own properties with wrapped around support, so there's a whole range of options. But early intervention, least restrictive models of care are always something that we focus on, and we will be in the future. What we build in the future will be very different, because regulation is very much moving towards a much smaller provision. So there won't be large care homes for people with learning disabilities, for example, and rightly so, because we want people to be able to live as independently as they can in their own properties. Has that answered your question?
Quick supplementary on broadly the same subject. Looking at that same report again, one of the other things I noticed were that we've got 44 adult care homes in the borough. One of my pet hates is I sit on planning committees, I so on that occasion these days, and not infrequently we hear where this sort of provision is proposed that yes, there's a need for it, absolutely there is, and this is what the London Plan says, and I do wonder whether there's perhaps a divide between what the London Plan says and perhaps what we and our local partner would say, given, yes, we need care homes, but actually sometimes they promote dependency in a way that's not helpful. And I just wonder if I can just pick up on that, see what comments perhaps either of you have got on that, please.
We have come from 2 years of obviously COVID requirements, and people understand that actually the best place to get your care from the pandemic is actually at home. And I would fully advocate the development and promotion of home care and wrapping care around people wherever we can, but there is often a need, and of the 44 care homes, not all of those placements are certainly by Hillingdon Adult Social Care. Many of those people would have chosen to occupy themselves, which we would like to promote our extra care services in favour of, where people can have their own flats, can have the same wraparound support on site, and get a range of services close to home for them. So in answer to your question, would we build more care homes? Well, maybe we might, if it's appropriate, to make sure that we've got wraparound services and that they are of a high quality. Will we build more extra care at this moment in time? We've got sufficient supply for our older adults, and we would always have our core offer at the least restrictive. So we would go through floating support, home care, extra care, care home before we, and maybe in the ranges of care homes and residential nursing dementia, before we consider that would be our least restrictive offer.
Okay, thank you. Okay, we've got 10 minutes left before the natural guillotine falls in place. We've got Darren and Tony wanting to ask questions. I think we can do it. This will be the most amazing meeting ever. Darren, you go.
So I have two questions. One of them is, what's the feedback since the social services has moved online? So to acquire a social worker, it's gone online. I think the service is brilliant. I've used it recently, or my parents have, and my grandparents. It's amazing. I just wonder what the residents' feedback is on that.
I'm going to let Sandra talk about the residents' feedback, but certainly the feedback I've had from the officer who has dealt with the Louise Forster has been exceptionally positive. So I just want people to be aware that I have been involved in that decision, and I was apprehensive at the start about older people and using technology. I am the world's worst cynic, and I was very apprehensive. But when we actually look at how people managed in the pandemic, it was surprising. And so I think I am pleased to see that it is working well. And I want to reassure people that if somebody needs a human voice, that will always be there in social care. It's not that we're going to go into robotic technology and we'll lose the human voice. That is not happening in social care. So Sandra can probably give a little bit more expertise about it, but that's my stance on it.
Thank you for your feedback, because actually it's good to hear that. Online assessment has been around for a while, but we are building up to a model of being able to accept referrals and contacts from people online and through virtual assistants through our contact centre, which will make a huge difference to the amount of time that people have to spend waiting. So by completing an online assessment, it's advancing the position of where you are and being able to be considered for services. And so although there are concerns from residents that they won't get to speak to a human, or that they won't get to be seen because they're actually filling something in online, it actually takes out steps in the process. And so it means for us, particularly things like safeguarding, referrals, people in need and needing assessment, it actually speeds up the wait time. So it's really positive. We will collect more feedback as we roll out more activity.
Darren, your second question?
Yeah, just on that, the service is amazing. We logged it on Monday at 9 o'clock and we had a call back by 5. I think it was 4:30, so that's brilliant. So that was really, really good.
I love it when committee members do mystery shopping before a guest comes.
The other question is on the Hillingdon Dementia Alliance. So I believe that came about in 2021, and I just wondered how that's grown over the last few years.
I'm not sure I can. Well, I think that the work that our team do around dementia is to be commended, to be honest with you. I think that we have, I'm not sure, but we have all sorts of them. We've got things in our libraries, our Toba Taffel. I think that is a shining example of how we've grown it. So I don't have the expertise in front of me to say how it's grown, but I think how our services grow are because we have a good service to deliver, we get people in there, we have good networks, and consequently services grow as a result of us going out there and delivering them. So I think that I'm pleased that you, Councillor Davis, acknowledged that it has grown. I don't know whether Sandra wants to add anything to me, but our dementia team are absolutely phenomenal. The work that is done by our dementia team, I mean, I've been to discos, and I know that's an old-fashioned word, nobody uses that word anymore, but please excuse me. And, it's absolutely fantastic to see the work we do and how we support people with that. So Sandra can probably be a little bit more specific about how it's grown, but for me, that is my view of it.
Thank you. The service has certainly grown, and the engagement with residents has certainly grown. I can't give you specifics as we speak, but I think that is something that I will look into and come back to you, because actually they, as Councillor Palmer says, provide some brilliant support to our residents, and it's aligned with a lot of the work the third sector are doing across the borough and keeps residents at home. Hillingdon, as a social care service, also has admiral nurses supporting residents at home with their carers of people with dementia. We've got specialist dementia services at Grassy Meadow and Parkview Court with specifically designed buildings. All of our libraries are engaged and are dementia friends. We have dementia friends trained in-house, and it's just about enabling and ensuring that we take seriously and we work with services to meet the needs of that population. And so I'll be happy to supply some more information from the public health team on that.
If I could just come back on that, Sandra touched on the admiral nurses, and I think I would just like to say that ties in for me with whether this borough is good to work for or not, because those admiral nurses have been with us for a very, very long time. And I've recently signed off something where that was quoted to me. So I think that they have excellent relationships with our residents, the admiral nurses. They know this borough like the back of their hand. They know the residents, and they provide a really, really first-class service. And I think that's a part of this that is understated. You don't hear about that so much in social care, but those two nurses that work for the admiral nurse in Hillingdon are nothing short of smashing.
Yeah, our relationships are so important in social care. Darren?
I just want to come back. The reason I asked that question is for that exact reason. The dementia teams and the health and social care teams don't get enough credit for how they deal with dementia patients. So I would just like to say well done, basically. Thank you.
Great, excellent. Well, Sandra, can you take that back to your team then, and say that we want to say well done to them? So that'd be very well deserved. Tony, you're going to finish us off with one or maybe two questions.
One, I think. Thanks for the paper. It was an interesting read. Just on the fair cost of care, I know it's on the top of page 4. The exercise was carried out, and it was estimated that the funding impact would be £4 million for Hillingdon, and yet we've only got 2.4 million this year. How are we going to make the gap up?
The fair cost of care exercise was, I would call it the fair cost of care challenge, was put to us last year, and in March of last year we formulated our plan, and we had to submit our final workings, which was a complete review with all of our providers' engagement, etc., on how we would, what they felt was the actual cost to them to provide the care to the council, either per bed per week or per hour of home care or per hour of supported living. We made our submission to DHSE as we were required to in October, and we received feedback that our submission was good. So we made estimates on inflation, we made estimates on what the actual costs were, and we did that in conjunction with all of our London colleagues, so we make sure that we're benchmarking accurately against other local authorities. The government, we set out that the cost of care exercise to bring providers to the level that we had determined with their input that was the right level of care and price for Hillingdon was going to be just over £4.5 million. However, the exercise is actually a 2-year process, and so it's an incremental step change to achieving that, and we have received £2.4 million of grant this year for the first year, 23-24 step change, and we have yet to be advised, and I'm certainly hoping it's 2.1 million worth of grant for 24-25, but we haven't been advised of that amount yet. And I would just say that actually inflation has risen since this exercise was done last March through to October, and that still puts significant pressure on the council. So this is a government initiative that we were asked to complete. We've done that. We still will have pressure on social care budgets as a result of trying to meet the required payments of providers this year.
I mean, when you know what that grant is, could you let Nikki know? Because I think we'd be interested in that, wouldn't we? Cool. Okay, brilliant. Okay. You can have, okay, June, I'm going to shut it down, but because it's you, you can have one question, as long as you switch your mic on. You can have one question. As long as you switch your mic on.
Sorry, at the back of your report, the first paragraph, the last two levels, there was a drop in referrals during COVID time from 1694 to, and then it went down to progressive this way down, then down again to 2,492 in the case. Now this year here you said there's a significant increase in overall referrals with 8,848 in 2019-20 and again 13,938 for 2022-23, an increase of 58%. How is this being managed?
That is going to have to be an answer for Sandra, and if we don't have that answer, that is probably going to be something we're going to come back to. June, can you go with it, or do you want to defer it?
Either's fine, yeah. If Sandra can answer it, great. If you want to come back to us, that's fine as well.
A kind of a short version of the answer. During COVID, people weren't referring, as you would expect. Lots of people didn't, and the legacy of that is that there are a lot of people now experiencing mental health challenges, and a range of safeguarding inquiries are coming through to us. We have a large team in the MASH, which is a multi-agency safeguarding hub, and that team triages all of those inquiries. So we currently have a large number of inquiries. The crucial figure, and the figure that I need the team to probably help everybody understand, is what converts to a Section 42 investigation. So those are the statutory safeguarding investigations that are undertaken as a result of somebody reporting. So on a quick answer would be that actually we want people to raise safeguarding queries and inquiries, and if our conversion rate is low to Section 42, then we're heading in the right direction. What I would like the team to be doing in this coming year is promoting more awareness and people being able to understand what is a safeguarding matter and should it be being reported in the way it is. What we don't want to do is to put people off. So it's a fine balance in getting that number right.
If I could just respond, I think the thing with safeguarding is we always are concerned when numbers are high, but I suppose I'm concerned if numbers are low, because I think it is more important to report than not report. So certainly under our Director of Public Health, we are doing much more going out into communities. I'm going out next week to a health workshop in Hayes at that centre. So we're doing much more work, and it is about getting out in our communities and particularly with what's going on at the moment around women's safety and things like that. It is important that we highlight to our residents that Hillingdon is a safe borough to report any form of safeguarding to. I've just had to give some advice to somebody today about making sure that we do a safeguarding report. Let's not, if we're thinking about it, we need to do it. It's not something that you can put off till the next day. So I'm confident that we will manage them, the referrals, and I would like to see them getting higher, to be honest with you, because that means, I don't mean that in a negative way, I don't want to see more people suffering with safeguarding issues, but I think we need to talk much more about safeguarding.
Thank you, Jane. Thank you, Sandra. Thank you so much for coming and speak to us. That was really, really interesting and useful. Before you go, is there anything else you want to say, or is...
I just want to thank the committee for the work you do. I do sit and watch it online. I know that means that with the review you're doing, that there's work coming my way, and I want to reassure you that I think it is a very, very good review you're doing, and I look forward to making some changes, hopefully within the council. I know children under my portfolio, but the Health and Wellbeing Board, I can already see that, I'm looking at the doctor's referrals, and I've made similar notes to Councillor Chandel. So I want to thank you for your work. I want to thank you for inviting me here to talk about my portfolio, and I would be only too pleased to come back should I continue to be Cabinet Member for Health and Social Care. And if there's a specific topic you would like to talk to me about, I'm happy to do that. So thank you, Chair.
No, thanks a lot.
And thank you to Sandra for sitting by my side and bailing me out when I don't know the answer.
No, it's fine. It's a team effort, and I know that because, as I said before, there's lots of different meetings and forums in health. And we have a shadow scrutiny chairs meeting to all the boroughs that Jane talked about, which sort of shadows the stuff that you do, and it's and ultimately, and even certainly within this committee, it's a team effort to try and get the best we can get. And I know I do know you watch the meetings, you talk to me about them, which is great. Sometimes you do have to break them up into bits, don't you? Watch them over 3 or 4 days, depending on how long the meeting was. But no, and I think I really like the idea of you as the Cabinet Member coming to speak to us at least once a year, and with Sandra as well, obviously, in terms of general updates. I think that's just very useful for us. So let's pencil in next March and hope we're all still around for that. Okay, all right, well, thanks. Like the others, you're welcome to stay, but you're very welcome to leave, and no offence will be taken if you leave, and I hope we go through the next ones quickly. Well, thank you very much. Okay, does anybody have anything to say on the Cabinet Forward Plan? No? Okay. Yep, fantastic. And I agree with you. And then if we go on to item 8, which is the work programme, essentially our next meeting is when we do our statutory obligation of getting reports from our health partners in the local borough, and I'm afraid you should bring a drink along to that one, because that one can last a couple of hours at least, if not 3 hours, because we have a lot of health people coming along, and in theory, they should provide us with written reports. Sorry, I'll let you ask the question soon. In theory, they should provide us with written reports before the meeting. In practice, quite often it happens after the meeting, but when that happens, Nikki circulates them and we try and get comments. But Philip, you had a question.
Just to reinforce the point that I made at a previous meeting, this is a statutory function. It's not nice to do. We do need the scores on the doors in terms of performance to fulfil that duty appropriately, really. So I just reinforce what's been said before about that, and ideally not at the last minute as well.
Nikki, can you remind our health partners of that and how it helps us do our job? And maybe, even if they can't get the final report to us, if they can get us something before the meeting, at least a week before the meeting, because we have a lot to read. Yeah, exactly. So if you could take for this point and remind them.
Yep.
Excellent. Okay, and then obviously beyond that, it depends what happens, in terms of, the new municipal year starting, and I might not be chair anymore. June might not be there. Jane might know. Who knows? Because obviously May.
Been there and done it.
Well, exactly. It's nothing's guaranteed in politics, isn't it? So we can discuss future work items after that. So is everybody happy if I call the meeting to a close? Fantastic. Oh, there's one item we have to quickly. We can close the meeting. Okay, it's not an important item. Okay, close the meeting now.
Can I